All right, Assalamu alaikum wa rahmatullah. Welcome back again. Thank you, Dr. Abdullah, for the nice introduction. And thank you for the SSBMT and KITE for the invitation for this satellite symposium. So as we know, many years ago, R-CHOP became the standard of care for treatment of diffuse large B-cell lymphoma. And we were able to cure actually majority of those patients with a median overall survival of 8 years versus 3 years, with the addition of rituximab to the backbone of CHOP. However, despite of that, 40% of patients, they will eventually relapse. And actually 10% from all comer, they will be what we call it primary refractory disease who have dismal outcome. And as you can see here, the median overall survival is very dismal for those who relapse after the R-CHOP upfront therapy. Of course, we will be able to cure some of them with the use of high-dose chemotherapy and autologous stem cell transplantation. However, many of those patients, they will not be able to either respond to this treatment or tolerate this kind of intensive treatment. And this is a retrospective review from a single center showing that there are some marker, what we call it ultra high risk features, and that's including primary progressive disease, MEC positivity, and high, intermediate high, and high NCC and IPI. If patient has one of these markers, one or more than one of these markers, the outcome will be very dismal. Identifying a subset of patient that they are highly refractory to the upfront use of high-dose chemotherapy. Similarly, the SCHOLAR one, which they pull data from 2 phase 3 trials and 2 observational cohorts, and they found a similar finding that the response rate is very dismal for those patients, around 26%, only 7% complete remission. And if you look to those who are primary refractory, the response rate is only 20%, with a median overall survival of 6.3 months. Very dismal outcome in those patient population. So for patients who are highly refractory to chemotherapy, we know that in general, cancer cell, they have a way to evade immune system, and evading this by upregulating certain molecules or secreting certain signaling molecule, TGF-beta, upregulating of the BD ligand, that will help the tumor cells to evade immune system. And actually, T cell have certain ways to navigate the immune system and clear the tumor. Of course, you need those tumor cells to release certain antigen, and this antigen has to be presented in a nice way to the T cells and recognized by the T cell. The T cell has to traffic to the site of the tumor cells and engage with the tumor cells by recognizing them. So the recognition is a very important aspect of the T cell to exert its function against the tumor cells. And then followed by the killing. Checkpoint inhibitor have been a great groundbreaking into the novel intervention and immunotherapy for cancer in general and some of the lymphomas. But unfortunately, this did not work with the diffuse large B-cell in general, not even cancer vaccine and others. However, improving recognition has been the key here, and CAR T cell help actually to improve the recognition of the cancer cells and direct killing of the lymphoma cells. So what is cancer cell? It is modified T cells that is genetically modified to express certain molecule that facilitate the T cell to recognize the tumor cells, and then they exert its effector function and kill the cells. And how we do that? By collecting the patient starting material, leukapheresis, sent to the manufacturing facility where the T cell expansion, selection, isolation, and activation and expansion happen, and then the transfection with the viral vector that will lead to the expression of the target of interest, either CD19 or BCMA, for example. And then this cells will be shipped back to the treating facility and will be infused to the patient after a lymphodepleting agent. And then the T cell will actually recognize easily the lymphoma cells and exert its effector function. We have now around 6 products with the target including CD19 and BCMA, and those 6 products covering more than 12 indications so far. But what we want to focus on in our talk today is the CD19 target, and specifically for treatment of highly refractory or primary refractory diffuse large B-cell lymphoma. I'll start to talk about axicabtogen lysolysyl, which is in short we call it Axicel, for the use of this product in the second line therapy for large B-cell lymphoma. I'm talking about specifically here the ZOMA-7 study. In this study, they tested the use of Axicel in a randomized fashion against the standard of care in a primary refractory patient age of more than 18, who are refractory, relapse refractory less than 12 months, or they are primary refractory to the first line of therapy. Patient has to be intended for high dose chemotherapy. That means they have to be fit in terms of ability to withstand the salvage chemotherapy and high dose autologous transplant. Then patients were randomized to Axicel or use the standard of care with platinum-based chemoimmunotherapy. And for those who achieve CR or BR, they will go to autologous transplant. And the primary endpoint was event-free survival. The median age was, as you can see here, around well balanced between two groups, around the age of 60, and this is what we see usually for patients who are fit for autologous transplant. However, you can see here that around 1/3 of patients actually their age more than 65. Of course, majority of patients they have advanced stage and advanced IPI, and 70% of patients they were actually primary refractory. Majority of patients they were actually diffuse large B-cell lymphoma. Very minority of them they were actually they have the rearrangement, the double hit or triple hit. The study met its primary endpoint with median overall survival for those who received Axicel was 8.3 months versus median event-free survival for those who received Axicel was 8.3 months versus 2 months only for those who underwent salvage therapy and autologous stem cell transplant, and after a median follow-up of 24.9 months. And the 2-year EFS was 41 versus 16%. Overall response rate was actually higher in the patient treated with CAR-T, 83% versus 50%. Majority of these were actually CRs of 65% versus 32%. In terms of toxicity, around 6% of patients they have 3 or higher grade of CRS, and median onset was around 3 days. Looking into neurological toxicity, 21% of patients in Axicel they have grade 3 or higher neurological toxicity versus only 1% in those who are treated with the standard of care. Median onset time to the neurological toxicity was 7 days. Longer follow-up showing that actually Axicel led to improvement in the overall survival compared to standard of care. After a median follow-up of 47.2 months, the median overall survival was not reached in the Axicel group versus 31 months in the standard of care patient. Despite that, 50% of standard of care patients they went on and received subsequent cellular immunotherapy, which most of the protocol, which most likely would be CAR-T cell at that time. Some data for quality of life showed some measures of improvement of the quality of life for those who receive Axicel versus standard of care, especially within the 100-day post procedure. And this is set the standard for Axicel to be the standard of care as a second line for relapse refractory or primary refractory diffuse large B-cell lymphoma. Another agent is the Lysocell, which is again CD19 CAR-T cell. This was also tested in a randomized fashion in the same patient population, relapse refractory less than 12 months, as who failed first line therapy. With the primary endpoint of event-free survival. In this study, it met its primary endpoint with median EFS not reached versus 2.4, but this is after a shorter follow-up. the median follow-up was only 17 months. And the median overall survival was not reached versus 29 months for the standard of care. Again, high response rate versus standard of care. And what's interesting here, the adverse event was lower. If we talk about grade 3 CRS and higher, was only 1%, and grade 3 and higher of neurological toxicity of only 4%. So we're talking about patients who were actually have primary refractory DLBCL and they are eligible for intensive chemotherapy. So what about those who are not eligible for intensive chemotherapy? There are 2 pilot studies that we would like to discuss today. For the ASTCT, we have the Alicante study. It's a phase 2 study, including patients who are not fit, who are refractory to the first line of therapy and not fit to go for intensive chemotherapy. Those patients, they actually roll into this study, and they allow in this study to do bridging, while in the ASTCT, the ZUMA-7, they did not allow bridging chemotherapy. And the criteria to go into this study was aggressive B-cell non-Hodgkin lymphoma, including DLBCL or high-grade DLBCL or high-grade follicular lymphoma. And the inclusion, the criteria for not to be eligible is by physician assessment plus one of the following criteria, which is age above 65 or younger age who had high comorbidity index of 3 or more, or those who have prior autologous transplant. The median age was around 70, and the refractory to first line was around 50% of patients. They are refractory to the first line of therapy. And the bridging chemotherapy, which is R-GEMOX, was used almost in all patients. And the response to bridging therapy was not significant. With the 50% of patients, they have either stable disease or progressive disease after the bridging chemotherapy. The complete response was around 71% investigator assist, and centrally assist was around 66%, which is quite impressive. With the best response was around the complete was 3 months, but the best response later on was around 90% overall, with the complete response of 79%. The median, after median follow-up of 12 months, the EFS was the median EFS was at 12 months, 12.3 months. And the median overall survival was not reached, with estimated 1 year overall survival of 78%. Again, grade 3 to 4 CRS was 8%, which is a little bit lower what we expect. And also the ICANS was around 14% grade 3 to 4. There was around 25% ICU admission in this study, and non-relapse mortality was around 9.7%, which is considered not an easy treatment to do. Another study testing the lysocell, the same patient population, which is the pilot study. Again, this is a single-arm, open-label phase 2 study. They include elderly patients who failed the first line of therapy, and then they are not eligible, they are not fit to receive intensive chemotherapy, showing again 80% overall response rate with a 50% CR rate, with after median follow-up of 15 months, the median PFS was 9 months, a little bit shorter than what we see with the ASTCT, and median overall survival was not reached, with a 1 year probability of overall survival of 70%. With that, I conclude, and happy to take any question. Thank you for your attention.